So all the microbiological support is, we have a very intensively good microbiological team of doctors who've been very passionate and committed, because we see a lot of infections. So you know that I cannot overemphasize that if we're able to treat all the infections that we see, so we wouldn't have many of the corneal blind. Perhaps 50% of corneal blind are due to active keratitis, or the scars that happen due to active keratitis, or even the bad complications. So that's the reason why we need to be very well aware of the spectrum of organisms that we have, which includes bacteria as well as fungi. But if you notice, it's kind of a half and half. So we cannot just go with empirical therapy. We need to know what exactly the patient has. It's not enough to just have a clinical diagnosis without sampling the cases of infective keratitis. For example, these are very classic textbook-like pictures for each of these entities that I've put up. So what is the need for scraping? We have to establish the microbial diagnosis, whether it's bacterial, whether it's gram-positive or negative, then what is the nature of the organism, low or high virulence, and then have culture and antibiotic sensitivity for these cases. We found out the hard way that just having fungal-like filaments which look hyaline is not fungal infection only, it's pythium, and that's how we learned. And they behave so differently, and they can just devastate the eye. And of course, luckily parasitic is rare, but imagine that you don't detect these and the patient keeps getting treated for some other cause because it looks like fungal, for example, in acanthamoeba, and the patient doesn't get better. So, and we have a sort of a small subset of mixed infections. So you're treating for one organism, but there's another organism as well. So that's all the reasons why we need to have proper microbiological evaluation. So is it enough to just have clinical diagnosis? Aren't we right most of the times? The answer is no. Even in the hands of experts, or when cornea specialists were sampled, so the results showed that the value of clinical diagnosis was 65%, which is okay, but that means we're losing out on 35% of patients. And even in those 65%, we don't know if the organism is sensitive to the antibiotics that we're using, so we could be on the wrong track, actually. So that's the reason why, except for the very simple peripheral corneal infection, all other infections of the cornea should definitely undergo microbiology. And when to scrape would be at first presentation. However, we can have very small ulcers, less than 2 millimeters, or it's already healing by the time the patients come to you, not in the center. So those cases we need not scrape. What do we need? The very basic set, which I'm sure many of you may not have done, except for one senior registrar that I can see, a senior resident I can see here. Nobody else would have done this for a while now. We're not touching this for a while now, but those of you who are in your own practice might have to do it. So you need, this is what the set entails, and it's very easy to set it up. So you need topical anesthetic, surgical blade, and this is the armamentarium that you need to take a corneal scraping. And sometimes we even have to do it under sedation or general anesthesia for children. Otherwise, you can do it at the slit lamp, or make the patient lie down. And if you have an operating microscope, just use that for scraping the eye. You can put a speculum, and make sure it doesn't get contaminated by the discharge or the debris, and keep the lashes away. So this is a simple video just to demonstrate how to do it effectively at the slit lamp. Patient is anesthetized. So don't scrape from the thinned out area, but rather scrape from the base as well as the active edges. So first you prepare it, smear it like that for gram staining, and just drop it on the slide that was for KOH, which will also have calcoflow white later under the microscope mount. And various media. The first one to inoculate is the blood agar, chocolate agar. Chocolate agar is most important because everything literally that can grow will grow in it. And we also take a non-nutrient agar, that is to rule out acanthamoeba, although it's very rare, but if we don't sample it in non-nutrient agar, we might miss it out. So we've learned it the hard way again. So this is a basic module for microbiological evaluation. The smears, as I mentioned to you, it has a 10% potassium hydroxide gram stain and Giemsa stain. We don't do Giemsa stain in all cases. Sometimes you might want to. And based on the clinical suspicion, our microbiologist will restain some of these. They decolorize the gram stain and use acid-fast stain if you're suspecting acid-fast organisms. In terms of culture, I just showed some of the media, but we also inoculate for fungi in potato dextrose agar or other media, and also use liquid media because you might have very tiny portion of the microbe, and then that might inoculate a liquid media more easily. So this is what a simple KOH mount would look like. And in our secondary centers, we have the doctors who are there. They take the scrapings and they look at it under a uniocular microscope. Just put KOH, which will sort of dissolve the cells, which are not the fungal cells, and you see the fungal filaments very easily visible. And nowadays we also add trypan blue exanth to the stain, so it highlights against blue color. And this is other stains where you can see acanthamoeba cysts. If you have plenty of cysts, then you can pick up these double wall structures just under in the KOH wet mount. And sometimes we can see microsporidia also, which we need a higher magnification, so which are very tiny looking oval-like structures. You can pick up a few, and this will require more experience as compared to KOH, which is the easiest. So if you rule out that it's not fungus, then you at least know that it's most probably bacterial, and you can start antibiotics. So the 1% calcofluor white is a specialized way in which you never miss. You almost 95% or even 99% of the times, or our microbiologists can pick it up because it just fluoresces in there, and fungus will not be missed out. Also, it will highlight microsporidium. There's a previous slide where you apply KOH and then 1% calcofluor white, and then you use a fluorescein microscope, and everything will just light up like this. So you can't miss microsporidia using that system. And acanthamoeba as well. So this is a yeast, sorry, it's a budding yeast that you can pick up. And finally, acanthamoeba, which are these, the same magnification. So you'll see that the cysts are much, much larger than the microsporial cysts. So this is acanthamoeba. And this is a newer entity. So you see that it looked a bit like fungus, but the major difference is that it's not having those typical, very rigid kind of septae. And you'll see these folds, they're called ribbon-like folds. And so our microbiologists noticed that this was different from the typical fungus. And we noticed that these patients were doing very, very badly. They wouldn't respond to antifungals, and we were losing their eyes. So finally we realized this was Pythium, which is a different organism altogether, doesn't respond to antifungals. I won't go through gram stain. This is very basic, but it's very interesting. Some of you may recall doing it, at least those who've done cornea training. So it's a very simple way of doing this. I'm not going through it. But the information it gives is very valuable. You can have gram-positive organisms, gram-negative organisms. So you know which track and what set of antibiotics you have to start for these two groups of patients. So this is gram-positive and gram-negative bacilli. Acid-fast staining is invaluable in rarer infections. So when your clinician has to provide some guidance to the microbiologist. So when you take the sample, you have to tell whether this is looking atypical, or depending on sometimes the history. Nocardia keratitis was associated with post-LASIK infections also. So and then there are certain clinical clues, like a wreath-like infection in the case of nocardia. So the microbiologist is asked to do the acid-fast staining, and you can pick up these very bright pink organisms, sometimes even as sort of colonies on acid-fast staining. And this is an actinomyces, very long, segmented-looking filament under 1% acid-fast staining. So that's pretty much what we do, and the basics for infective keratitis in terms of sampling the ocular microbiology. Thank you very much. Thank you, Manisha. Yes.
For taking keratitis samples,
Yeah.
how to increase the yield? Because many times we do send the samples, but no growth comes of it.
So we have to, that's why we have to inoculate the media in which almost everything grows. So, and smears are most important. So initially, whatever amount of material you take, so make sure you don't take it from the central thinned out portion, but take it from the edges of the spreading ulcer. So that's number one. And the gram and KOH is the most important. So that's the crux of it. So you make sure that you apply your material well to that. Afterwards, the media to inoculate, always select either chocolate agar or blood agar. So many people think that it's fungus, so let me do the potato dextrose agar. But you do the blood agar, chocolate agar first, and then do a liquid media. So this should be your sequence. So you're more likely to get growth in these, whether it's fungi or whichever organism, except for acanthamoeba, will grow in these reagents. And then the other problem is that the microbiologists have to be clued in. If you're working in a hospital when there's general microbiology, for them this is very minuscule amount of sample. They deal with huge amount of samples, biological samples with cc's and cc's of pus and so on, or infected material. Whereas we just give a small minuscule of amount, so they see nothing initially. So the ocular microbiologist has to be trained to try and pick up from that specks. They will know that. Once you tell them you're looking for those specks, that's what you want. Because for them, GPCs and all are commensals. They don't know those GPCs are causing the corneal infection. So you have to have a dialogue with them. So, and no growth, there are different reasons, because there may be a time lag from when you send the samples to when they inoculated it. So there, many of them are quite delicate in that way, the organism, and the load is very low. So you have to immediately provide it the environment it needs, the temperature and so on. So if there's a long chain in transporting them, it won't grow. It dies in transit.
Generally, in our setup for acanthamoeba, we don't send the sample at the beginning itself.
Yeah,
So how, after like we take the samples for bacteria and fungi,
yeah.
and we start the patient on empirical therapy, in how much time should we repeat, give a washout, and then start send repeat samples if the first sample is
Yeah, so what we follow is that in 48 hours, if we get microbiology, there's nothing, and we got negative, smear negative. In 48 hours, we have some idea about rapid growing organisms like bacteria. So if everything is sterile, then we repeat the smears again. And then we look at the clinical picture. If we think it's going to be acanthamoeba, then, but we do acanthamoeba in the beginning itself, being an institute setup. So after 48 hours, after that, then you might venture onto a biopsy. If that's the third, because it's a cornea, you can't scrape it too many times. So the next intervention would be a corneal biopsy.